Science has changed, medicine has changed, business has changed, and it will keep changing. And it's through your efforts in this room that we'll see another 30 years for CBA as well, if not beyond. Thank you. Yes.
Okay, thank you so much, Senator Dr. Claire Nam, for your inspiring speech and best wishes to CBA. And the next, we will move to the keynote speeches led by our President-elect, Dr. Qi Zheng, and another Angela. So, and our immediate past president, Dr. You Li. Let's welcome them.
Thank you, and good morning, everyone. Thanks for coming. This is an early Sunday morning. I know many of you probably are should be relaxing, right? But again, thanks again. So, well, first I want to say welcome to the keynote session of our annual conference. As you can see from our agenda, with the theme of accelerating innovation and equity and bridging science, strategy, and regulation for future of global health. Our keynote session will have introduction of the leading global life science membership association, which is DIA. We'll also have a senior executive from the renowned global pharmaceutical company to share with us how this company is advancing their rich pipeline and bridging the new medicine to
One of them, not surprisingly, is in the AI space. And the other one I'm going to talk about today, which started with an executive roundtable on obesity drug development. Just like CBA, we cannot accomplish you have student programming, and it's very important to continue to educate the next generation of scientists and regulators, and to continue to emphasize the importance of science, scientific funding, and creating a pipeline that really will ensure that innovation across the globe continues to happen in the future, because all the advancements we're seeing today would not have been possible without the investments of the past. And so, in terms of the science focus areas, as I said previously, today I'm going to be talking to you about our first one, which is addressing chronic diseases, facilitating the efficiency of obesity drug development. But in addition to that, we have a number of other partnerships and priorities. And so one of them is in the area of cell and gene therapy. I spoke about that at the last CBA annual meeting, and we're really happy that next week we'll be hosting a specialty meeting focused on regulatory harmonization in cell and gene therapy. If you're interested to find out more, talk to me. It happens on June 15th in Washington, D.C. We also do a lot in the clinical trial innovation space. We do have a consortium, as I said, that focuses on the utilization of AI in drug development, and is a public-private partnership with a lot of involvement from the academic technology sector as well. We organize an annual meeting in RWE, and Julia has been a big part of that meeting and has sat on the committee before. And then in Europe, we have a lot of work that we do in the sustainability of clinical trials and medical product development, and have come out with a number of consensus publications. I would love to tell you more about our work in patient-reported outcomes. If we have time during the break, we do have a program focused on defining patient tolerability in oncology trials. And we also organize a number of reliance workshops, both in Europe, Latin America, and the Middle East, because in a time when science is advancing so quickly, and it may be hard for all countries to have the resources to keep up with that advancement, it is important to have tools such as regulatory reliance to make sure that products get approved and get to patients faster. So I'm going to talk about obesity drug development, and that's why I thought I would just set the stage with some quick review about all the really fast developments that we have seen over the last few years. In 2024, there were official supply shortages that persisted throughout the year, despite limited reimbursement of the drugs that were approved as anti-obesity therapeutics. Incretin mimetics really expanded their proven benefits beyond obesity to type 2 diabetes and even some neurological conditions. And so it's not surprising that at that point last year, there were many medium and large pharma companies that had pipelines developing anti-obesity drugs. At the same time, as we're witnessing this explosion of clinical trials in the space, in the real world, it is interesting that 30% of the patients on GLP-1s discontinue therapy within the first month. And then only 27% take the products and medications as prescribed. And then 33% stay on their medication after 1 year. Also, we have seen over the last couple of years that many patients are going to non-FDA approved drugs that are generated in compounding pharmacies, and that has created some safety concerns. So there is a lot to unpack there, but we really have been focusing only in mostly in the area of drug development. And so the one thing that I like to show is this figure, which again demonstrates visually the explosion of publications that has happened over the last decade to make this work in the clinical trial space now possible, and then to see the impact that we're seeing on patients already through the several approved medications. So it's very important to continue supporting the research all the way from the basic translational to clinical trial space in order to see innovations make their way to patients. And of course, there are issues about access that we need to continue to work on. So because of the increase in the assets in the pipelines of many pharma companies in 2025, there were several important milestone events that happened even just the first quarter of this year. In January, the Lancet Commission on Diagnostic Criteria of Clinical Obesity redefined clinical obesity as a chronic disease caused by excess adiposity distinct from preclinical obesity. At the same time, also in January of this year, the draft guidance from FDA was revised. So the second revision was issued. And then at that point in time, if you looked at the pipeline, there were 157 clinical stage assets, 7 in phase 3. And the exciting part of that is that over 60 different mechanisms of action. So much work is going on in the space, and there is work that is trying to bridge between the clinical trial and the real world, the gap that still exists. So all of that is really very promising. And the last thing I wanted to mention before we dive into some of the work I wanted to share is that in 2025, also the Breakthrough Prize in Life Science, which is considered the Oscars of science, not surprisingly awarded 5 scientists this prize for their characterization of a GLP-1 because based on their findings, the development of the treatments for obesity and type 2 diabetes was possible. And it's been really great to see that the GLP receptor agonists also have been now found to have an impact on not just obesity, but also mental health disorders, cardiovascular disease, and then at the same time, type 1 diabetes and the management of neurodegenerative disorders such as Alzheimer's and Parkinson's disease. So in April of this year, after 1 year of planning, we were able to convene the DIA, an executive roundtable on obesity drug development. We brought together 7 division director and center director leaders from FDA together with pharmaceutical industry experts from 7 different companies, some CRO and academic representation, and of course, patient advocacy organizations. And we were able to convene this workshop, which focused on identifying and discussing the current bottlenecks in obesity drug development, and also thinking about how to strategize and map out the optimal path moving forward toward enhanced collaboration. So the way we designed this, and I was very happy to have the opportunity to work on the program together with Julia Luan, who is one of the former CBA presidents that you saw on the photographs earlier. We organized it in 3 different sessions, so we could have each one of them focused on a specific area of a need. And so the first session was focused on improving the efficiency of obesity drug development. And the topics that we discussed here were quality of weight loss, the need to define endpoints for lean muscle retention and maintenance. We also looked at the functional endpoints, including patient-reported outcomes, and how we can think about the holistic evaluation of weight management benefit. We looked at the comparators that need to be used in clinical trials, and we examined some of the issues for pharmacovigilance and safety. At the end of the session, we concluded that it is very important to try to validate endpoints that can measure quality of weight loss and body composition and that are able to measure physical functions. As we know, participants in clinical trial and patients with obesity are very heterogeneous, so it would be important to be able to stratify based on baseline physical function. We also concluded that trial design has to involve and balance the flexibility and patient retention with regulatory rigor, because without participants staying on and participating actively in the clinical trial, it would be we would be unable to reach scientifically valid conclusions. And of course, we have to continue being focused on safety and outcomes. But in the current environment, the requirements for safety make the trials very large. So a patient-centered approach is always very important to define success. And what we heard both from our academic colleagues as well as patient advocacy organization is that it's very important to continue including psychosocial and functional well-being as part of the endpoints that are being considered and as we think about the clinical trial design. So the second session was focused on assessing the comorbidities associated with obesity, and we considered three different subtopics here: clinical trial design, current and future endpoints to assess comorbid conditions, and how or is it possible to have one trial for multiple indications. So the key takeaways from that session were that when you assess comorbidities that are associated with obesity, it's very important to develop and validate surrogate endpoints, especially those that are linked to real-world outcomes. But we also had to acknowledge that getting to a surrogate endpoint can be very difficult. And that's why it may be worth considering basket or umbrella trials if investigators can come up with well-justified designs, endpoint strategies, and continue to engage with regulators as they think about their trial design. It's also worth considering using composite endpoints or co-primary endpoints to capture all the nuanced benefits that can happen during the clinical trial. And as I said earlier, to evaluate patient-centered outcomes like mobility, sleep, and daily function, because we want to be able to reflect the current state of obesity disease science and the needs of patients at the same time. And then finally, the third session was focused on combination drug products and treatment regimens. And here we looked at the design of trials for fixed dose combination products as well as combination treatment regimen. And we discussed how in the future, the combinations may involve fixed dose combinations, so more than 2 agents in one product, add-on regimens, and sequential or switch regimens. We also talked about how we could improve outcomes by combining mechanisms that are being targeted. So considering thinking about targeting fat loss and muscle preservation at the same time, or GI tolerability and efficacy. And then we talked about how streamlining product strategies can really help reduce confusion and improve access, especially when you're treating people who have comorbid conditions like diabetes and obesity. And so in terms of the next steps, next week at the DIA Global Annual Meeting, we're going to have a session chaired by Julia Luan. It happens on June 18th at 4 p.m. In Washington, D.C., and we're going to talk a little bit more in depth about the findings of the discussions during the executive roundtable. We'll also have FDA and industry representatives on the panel to weigh in and talk to the audience about the next steps. We're also preparing a publication in Global Forum where we're going to share some of the key insights with the broader audience. And then as some of the discussions that we weren't able to have in April because of limited time, since it was a one-day meeting, we're going to have another one-day event on November 18th to specifically address the compounding issues that I mentioned earlier. DIA is also proud to be assembling a consortium that's going to focus on standardizing the clinical trial measures that are being collected by various organizations as they design their obesity clinical trials that will allow future data pooling and eventual validation of endpoints in the space. And then because we did have the discussion here with FDA, we're looking forward to having additional discussions at our European annual meeting with EMA, and then to continue having other events around the globe, including an obesity session in Egypt later this year. So speaking about events, I would be remiss not to mention the successful DIA China annual meeting we had last month. Hopefully some of you were able to attend that. It was very well attended, and we really appreciate again the partnership with CBA as we think about the topics that are important to cover in the future as well. We also have our DIA Global Annual Meeting happening next week in Washington, D.C. And I know Angela mentioned how important our partnership is. So we thought we would provide a QR code here. So for everybody who is a CBA member, if you scan this code between now and June 15th, you'll be able to get fully free registration to the DIA Global Annual Meeting. We really hope to see you there. And we're very excited that we're going to have the FDA commissioner speaking at our plenary together with the executive director for EMA and the new CEO for MHRA. It will be the first time they actually are meeting with each other. We also have a wonderful presentation by one of the first patients that participated in the clinical trial for sickle cell anemia and was cured, and the AAAS CEO, Sudeep Parikh, who is going to talk about the importance of investments in science, as well as the very famous innovator, Doug Melton, who works on type 1 diabetes cell therapies, and he has appointments both at Harvard as well as with Vertex as a research fellow. So I'm very delighted to be the moderator for this panel, and I think it's going to be a very exciting DIA Global Annual Meeting. As Senator Dr. Lamb mentioned, this is such an important time for science, and we really hope to continue to be in the middle of all the discussions and be able to facilitate collaboration against among multiple stakeholders in your community, and our partnership is very important to support those goals. Since I mentioned our global annual events, I thought I'd provide them here in the slides as a reference so you can see what's happening the rest of the year that DIA is organizing across the globe. And with that, I want to thank you for your attention, and I look forward to the discussion on the panel. Thank you again.
Thank you, Maria. I think we got a very detailed introduction of DIA. I'm hoping with a collaboration between the DIA and the CBA, 2As now, yeah. So I am hoping it will be truly beneficial to members across both organizations, right? And I'm also hoping to see more members from DIA next year, maybe coming to our annual conference. Let's give her another round of applause. Let's take a picture together very quickly. And while we are preparing for that, I also want to share with our attendees, because we also have online attendees. So in the interest of time, we'll save our Q&A at the end of our session. Okay, and also online attendees, please remember you have the Q&A chat, you have the question chat. So please send your questions through our online version. We do have our volunteers collecting all the questions. Okay. Okay, let's take a picture together and we'll be. This is the award CBA presented to our DIA representative. Thank you, thank you. All right, I really can't wait for our next speaker. It's my really great honor to introduce our next speaker to you. Who is this? As a Senior Vice President, the Global Head of Medical Affairs, Oncology, Dr. Bob Lee leads an ambitious team that is helping drive AstraZeneca's vision to redefine the future of cancer care. Prior to, even though I know Bob actually doesn't need the detailed introduction, but I do appreciate the opportunity for me to introduce some background of him. Okay, prior to joining AstraZeneca, Bob actually worked as a clinical medicine and as a medical oncologist of more than 2 decades. And during that time, he served as a physician scientist and a vice president and global research affairs at Memorial Sloan Kettering Cancer Center. We all know that MSK, right, which is very renowned hospital. So he's also co-director of the MSK multidisciplinary Zurich liquid biopsy team. With a strong passion for clinical research and clinical care, actually Bob has served as a PI for multiple pivotal trials for precision medicine. He also has published more than 100 original articles in prestigious scientific journals, including New England Medicine and also Nature Medicine, Nature, and Lancet Oncology. Congratulations. Additionally, Dr. Lee is also a vocal advocate for international regulatory harmonization and an active participant in government discussion between the US, Australia, and China on the future of cancer control. And it's my great honor again to invite Dr. Lee to our event. Please join me in welcoming Dr. Lee.
Thanks so much, Dr. Angela Zhang, Dr. Angela Meng, Dr. Yu Li, and the CBA leadership for this opportunity to share a few words about the medical affairs revolution. And also congratulate CBA for the 30th anniversary, such a remarkable achievement. And really, I am mission aligned with the work you have been doing over decades, championing global collaboration. I want to echo the words of Senator Lam earlier, that collaboration leads to innovation, and that this is an era of so much revolution, whether it's digital, computational, AI, technological transformation, or otherwise. This is an era of major change. And here I just want to spend a few minutes to share, there's a bit of revolution going on in the biopharmaceutical industry that actually does affect multiple stakeholders in the whole ecosystem, whether you're in government or you're in academia or patient advocacy. So I'm going to use oncology as a therapeutic area as an example, but I think this will have implications for many other therapeutic areas going forward. So as Angela had mentioned, I come from MSK, a really classic ivory tower cancer center since 1884, and the tradition was to build the best of the best. It's the first and still the largest private cancer center in the world, and we just be the best. They come to us. We don't have to go to them, and that's sort of an elitist mindset that still has some cultural heritage, and it's a model that's really worked. It's also a model that's been propagated successfully since 1971 by President Nixon when he signed the National Cancer Act, otherwise known as the American War on Cancer. And this really codified the NCI designated comprehensive cancer centers across the country. There are now about 60, more than 60 of them across the center, across the country, and really being the model for the rest of the world. It's a singular focus on fighting cancer through multidisciplinary care, elevating the standards of practice, and also ushering and accelerating clinical trials, which has made remarkable advances in terms of reducing cancer mortality. So it's a model that's worked. And the rest of the world has largely followed. Where I grew up in Australia, we have different comprehensive cancer center that's been branded in that way, really following the NCI American model. And in China, there are cancer hospitals being erected, really dedicated to that multidisciplinary care and clinical trials, really following that model as well. But 50 plus years has gone by, and the world has really changed. And it comes to a point now that this model is no longer a sustainable one. Yeah, this is a paper we published just a few months ago, but this is looking at 2022 data that the global R&D spending in oncology by the pharmaceutical sector has now surpassed $80 billion a year. This is outpacing NIH, NCI spending 10 to 1, 15 to 1, and this ratio gets even more stark a contrast. And NIH, NCI, of course, used to be the world's biggest funder for cancer research. That's no longer the case. The pharmaceutical industry is really putting a lot more resources behind, and it's growing at exponential pace. And despite this, the clinical trial enrollment rate is less than 5% around the world. It's 7% in the United States, despite decades of effort in increasing the access of clinical trials to more diverse patient populations. But the truth is the vast majority of patients miss out on the very best of cancer care. That's endorsed by guidelines and society as the best treatment to improve the outcomes of patients with cancer. And yet more than 90% of patients miss out. That's a fact. And because of this, it's created a bottleneck because so few patients are able to get on. The R&D timeline takes, on average, about 10 years from IND phase 1 to registrational approval and market access. And many, as you know, most drugs actually fail this process. And go to the sort of so-called drug graves, right? And lots of investment, and only a few really make it to the market. And this is really becoming an ecosystem with a great bottleneck that's unsustainable, and therefore advancing health equity in access to clinical trials is not only a right thing to do morally, but also is now a business strategy for the future of the pharmaceutical industry and for drug development at large, for sustainability around the world. So this is a story, I'm taking it from an oncology perspective, but as you heard, we heard from Maria and the DIA work, there's a lot of energy behind obesity drugs, the next generation of obesity drugs beyond GLP-1. There may be a similar story coming up. If we only relegate this to academic medical centers alone, the rest of the populations may miss out. And this may create a huge bottleneck in terms of drug development. And so we imagine a new paradigm from cancer center shifting to cancer networks, where it's no longer the academic medical centers or cancer centers that's really doing everything, but in partnership with community centers, community sites, pharmacies, local clinics, GPs, and patients' homes, aided by visiting nurses and clinicians and technology. That through technology and collaboration, we may create a new ecosystem where the new innovations or the new drugs being developed go to the patients wherever they are, instead of them jumping through hoops just to get onto to see a doc in the academic medical centers. And this way we may expand access, democratize access to innovation, and radically accelerate the R&D timeline so that we see breakthrough after breakthrough after breakthrough, not every 10, 15 years, but every 2 to 3 years. And this way we do it at scale, we can see the cure for cancer in this lifetime and in eradication of many other diseases as well. So that's what Mars is about. This is a medical affairs revolution spirit. It's really a spirit of collaboration and innovation. This is not the Mars of Elon Musk, and it's certainly not the French Revolution, as I tell my team in medical affairs at AstraZeneca. This is a spiritual revolution. That's why it's an S. We really have to break silos, both internally but also externally, to build that cancer network, a network model, both in the US, but also around the world. And that requires a lot of mindset shift. It's not so much holding things tight to our chest, but really a lot of open sharing, a lot of copy and paste. Of course, there's proprietary things that you have to be very careful, but the majority of the everyday things we do really could be shared, and that could be learned from one another. And that does require collaboration to really move the needle across the ecosystem. So how does that really apply to the very thing we do in the pharmaceutical industry? Well, at AstraZeneca, I can share that we have a bold ambition to eliminate cancer as a cause of death. That is the mission for AstraZeneca Oncology. And this is really attacking cancers from multiple angles, multiple mechanisms of action, whether it's cytotoxic cell kill with the next generation of radioconjugates or antibody drug conjugates replacing conventional chemotherapy, or is it activating the immune system through various checkpoints and cell therapy approaches, or is it also treating cancers early with oncologic principles, treating early, smarter, hitting it harder with various forms of combinations, and then leveraging transformative technologies to accelerate their and expand their impact. So we have, as you can see, a lot of drugs in the pipeline. At this ASCO, which just finished earlier in the week in Chicago, we had presented more than 80 abstracts of original research of AstraZeneca drugs with 10 medicines that are already in use by patients, but also 10 others pipelines that are being tested in clinical trials. That included more than 20 oral presentations, including 2 plenary presentations and a special late-breaking plenary session with 3 simultaneous New England publications at this ASCO. So this is really a big investment in R&D, a big focus in science. But if you can take a step back, if we don't enable the access of these medicines to the wider population, to the 90% of patients who actually miss out on clinical trials, this road is going to be very long and arduous. It's going to be very slow. It's going to invest a ton of billions and billions of dollars will have to pour into this, but the needle is going to move very, very slowly. And that's why it's very important that while we attack the cancer from different angles, we also create through collaboration an ecosystem that will enable access to medicines and to innovation. That requires not just AstraZeneca, but really the entire ecosystem, whether you're in biopharma, or you're in government, or you're in academia, patient advocacy, and many other stakeholders. So this is what medical affairs in industry can do, because as you know, our R&D function and R&D colleagues are laser focused. We got so many new trials and huge investment into each trial. We heard from Maria the regulatory stringency, and we need the DIA's leadership to collaborate with FDA and others to really maybe innovate on the endpoints and on the clinical trial design. But these things move not at speed of light. You know, they kind of move incrementally. So we can't afford to miss the mark with regulatory endpoint. One trial, one question. You got to laser focus to get the drugs approved onto the market. But at the same time, we have 10 other questions for a trial. That's where medical affairs to come in with companion trials that could really move the needle at the simultaneously. Maybe for a much lesser cost to the registrational trials, we could actually expand access to more. We can completely change the inclusion-exclusion criteria. We could change the endpoints. It's not a registrational trial. We can leave it to the limits of our imagination to expand access. We can allow local labs, local imaging, telemedicine, remote monitoring, so that this innovation gets accessed by patients in really remote communities. And then getting that real-world data back, which will be really important in terms of generalizability of the innovation. So we're also investing in above brand ecosystem shaping initiatives. And these are, you can see, not linked to any of the AstraZeneca drugs, but here we have investments in early cancer detection, in precision diagnostics, in guideline-based care, and also a focus on patient experience and the patient journey with a health equity vision behind all of the above. So these are concrete initiatives that we are rolling out around the world to help patients. And of course, biomarker testing will lead to better access in precision medicine. Liquid biopsy will lead to better early cancer interceptions, as we heard from the SERENA-6 data at ASCO. And this could also be a non-invasive tool to expand access to genomic-guided precision medicines. And the digital computational pathology revolution, where patients may get not only their H&E slides, but all the biomarkers scanned within seconds by AI, uploaded onto their computers, and to be able to access the precision medicine that they need, wherever they may be. And of course, we need innovation around drug trial designs and master protocols. We're also looking at decentralized clinical trials that may not be accepted by the FDA as a registrational trial yet, but at the same time, we could start to provide these real-world evidence through decentralization, shaping guidelines, expanding labels, providing better market access to innovation much earlier, so that this is all in line with actually pharmaceutical business strategy. And of course, a focus on the adverse event, the patient experience. And, you know, in HIV medicine, there used to be this directly observed treatment where nurses would go to patients' homes to put in a logbook whether they took the medicine or not in sub-Saharan Africa. And that initiative of DOT was absolutely critical in the success of beating the HIV epidemic back in those days. And today, you know, we can really do that on the app, on digital tools, and scaling it through technology and providing education and empowerment at the same time. So this is work around the world. In Australia, we have a public-private partnership. We're partnering with the Australian government, who's investing hundreds of millions of dollars into the Australian Teletrial Program, or the ATP. And this is a program where we can really have one trial open in an academic center in Sydney or Melbourne, but then 10, 15 other sites in rural Australia, in the outbacks of Australia, opening at the same time, getting access to our innovative molecules like the T-cell engagers in Outback Australia without additional red tape, just one trial activated in the center, 10, 15 others at the same time. Of course, a lot of coordination. The PI in the major city would have to be coordinating and overseeing the rural community oncologists who are also seeing the patient and the nurses who are helping them. But the patients, through collaboration, are able to maybe only travel to Sydney or Melbourne once or twice and get the majority of their care close to home, and thereby expanding access. And if we can do that in Outback Australia, why can't we do that in rural America? Right? We really need to break silos, cut the red tape, public-private partnership to really make it happen. So our patients here in the US, no matter where they live, get access to the latest and the best. There's a lot of synergy throughout Latin America. We have the Pan-American Cancer Consortium that we just kickstarted at ASCO in partnership with ASCO and Bloomberg New Economy. And this is work that's synergizing across the American continent with US and Canada clinicians and experts, synergizing with those across all countries in Latin America through international tumor boards, molecular MDTs, sharing of protocols in lung cancer screening, actively shaping guidelines, publishing, and then ultimately implications for national cancer control plans to drive market access to innovation and medicines, also in economic investment. And of course, a lot of work that's going on in Europe, and certainly used to be the powerhouse in clinical trials. It's sort of lagging behind nowadays the US and even Asia, but now a real opportunity to reinvigorate the innovation in Europe, as there's a lot of rethinking going on in this new era. And when it comes to China, there's vast potential in China. It's a bottleneck in these coastal cities of Beijing, Shanghai, Guangzhou, and the patients jump through hoops to get into these centers. They will line up for 6 hours to see the doctor for 5 minutes just to be told they get this medicine and they go home. I mean, it's a lot of pain, a lot of suffering. It's unsustainable. And there is really a push by the government to decentralize access to all communities. Second, third tier cities in China need access. I mean, when we say second, third tier cities, they are like 10 million people each. These are mega metropolis in China, the fastest growing cities in China with double-digit GDP growth. So this is really an opportunity for investment actually in China. And then even the fourth, fifth tier rural counties, there's a really huge population, a lot of patients in need, and there's a lot of contribution they can make in the war against cancer. So a lot of public-private partnership with foundations and charities, including Beijing Union Charity Foundation, and then in partnership with various agencies and academic institutions all over China to expand cancer networks all across China, not just in the ivory tower cancer centers in the coastal cities. And that approach with the digital AI revolution that is going on really has the opportunity to leapfrog with big data and access and discovery pipeline and acceleration of drug development. So, as many know, there's a common prosperity national strategy, and this is linked to the common health agenda in Healthy China 2030 as well. So health equity around the world really should not have any political divide. It's really a common mission in China as well, whether you call it common health or otherwise. This is about access to medicines. In the US, where equity is getting a little bit more sensitive, a political term, this is about driving health access, including for patients all over rural America. And that's why we're very keen to expand access in rural America. We've had, just trying to advance the slide. Yeah. So we're doing a lot of mass field trips. The Rocky Mountain was the first stop, but really we're keen to accelerate access to not just in Colorado, but to South Dakota, to Montana, to Wyoming, to New Mexico. We're going to expand access to trials in Alaska, and AstraZeneca is also doing work in Puerto Rico, trying to expand access to our clinical trial pipeline over there. And I think through a lot of collaboration and technology, this is readily doable. And we have to start with the basics first, but this is ready for leapfrogging in the very near future. And that's why I think I applaud the work of the CBA over the last 3 decades. I think that's built a really solid foundation about global collaboration, US, China, but around the whole world. And in this new era of technological revolution, it's time to take off to Mars. Thank you so much.
Thank you so much for a wonderful talk, Bob. I think after this, we all will remember the new Mars. Thank you. Also, the spirit from the medical fair, I think especially when Bob highlighted the China part, that one really resonates with our CBA vision. Yeah, so on behalf of the CBA, we want to present you the award for your brilliant achievement award for contribution to science. Thank you, Bob. Let's take a picture there. Yeah. Thank you. Thank you. Yeah. All right. Thank you. Thank you. Thanks, Bob. Please stay on the stage. Yeah. Again, we'll have another great speaker. I really can't wait. Maybe you can tell something from our agenda already, but still want to take the opportunity to introduce my old friend, actually, to you. Dr. Hong Kai-ji is a full professor, associate chair for education, and a graduate program director in the Department of Biostatistics at the Johns Hopkins Bloomberg School of Public Health. We all know that School of Public Health is the #1. Dr. G is so low profile, so I do want to share some more detail with you about him. So Dr. G is an elected fellow of the American Statistical Association, and his research focuses on developing statistical, computational, and machine learning methods. I already mentioned the keywords maybe many of you are interested in, right? And also, along with the software warehouse tools, I did have questions for Dr. G already, software warehouse tools, for analyzing high throughput omics data, including bulk or single cell, and spatial transcriptomic and epigenomics and immune repertoire data. Also, Dr. G applies those approaches to decode gene regulation, many of the basic researches. I think we don't want to go to all the detail because Dr. G will have a very good talk for us. Especially, I also want to thank Professor G. Actually, this morning he drove from Baltimore to this area for around 1 hour. Really, thank you. So please show our warmest welcome to Professor G to the stage. Yeah, this is next. Yeah, I'll highlight this one.
Okay, first I want to thank Angela and the CBA for inviting me to this meeting. Obviously, this is my first time attending this meeting, and then I appreciate the opportunity to get to know so many new friends here. And I've never worked in pharma industry before, so it's also an opportunity for me. Okay, it's also an opportunity for me to learn a lot of new things from you guys, okay? And as Angela said, my research team is mainly a computational team, and we develop statistical computational methods for analyzing omics data. And we also combine these methods with new technology to study both basic biology and the human disease. And for today, I'm going to share some of our recent work and about applying computation to help us understand the tumor-infiltrating lymphocyte in immunotherapy. Okay, so obviously this is a collaborative work, and it's impossible to get it done without our wonderful collaborators. So we have a lot of collaborators listed here. And in particular, I want to thank Dr. Kelly Smith and Drew Pardo and their labs. And they're both from Johns Hopkins School of Medicine and the Bloomberg Chemo Institute for Cancer Immunotherapy, and also for all these other collaborators. And if you are interested in the details of my talk, you can go to this reference. I know like I have a limited amount of time, so I'll try to just give you the main message. And let's start with some background. And this talk will be about basic research, and our topic is tumor-infiltrating lymphocytes, or TILs. And then these are key players in tumor microenvironments and can influence immunotherapy response. And among the TILs, we are particularly interested in those cells that specifically recognize tumor antigens, including MANA, which stands for mutation-associated neoantigen, or TAA, which stands for tumor-associated antigens. So MANAs are tumor antigens resulting from tumor-specific mutations that you usually do not see in normal cells. And the TAAs represent self-antigens that are upregulated in tumor cells compared to normal cells. So both these type of antigens may be utilized by immune system to distinguish between tumor cells and the normal cells. And because tumor antigen-specific cells can directly interact with tumor cells, studying these cells therefore are important for us studying immunotherapy. Is that sound okay?
Sorry, Tina.
Yeah.
Oh, sorry.
Please, for our online attendees, can you please keep yourself on mute?
Is it okay now? Okay. So studying these cells is important for us to understand why immunotherapy works and why some patients respond to the therapy, whereas the others do not. However, study tumor antigen-specific cells, T cells or immune cells, are not easy for several reasons. First, among all the tumor-infiltrating lymphocytes, a large fraction of them actually comprise cells that do not directly recognize tumor antigens. Instead, they recognize like bacteria or flu or bacterial or virus antigens. It's okay.
Yeah.
Let's try to for other microphones in the room. Also, please, our host, Anna host, please mute our attendees when they are entering the meeting. Thank you.
Okay. Let's do some.
I apologize for the tech.
Just take a break.
Okay. Yeah.
It's a long morning session. It's all good now? Okay, good. So as I said, a large fraction of the TILs actually recognize non-tumor antigens, such as antigens from bacterial or viruses like flu, COVID, EBV, etc. Only a small subset of the TILs actually recognize tumor antigen. Okay, so we are interested in studying those. However, identifying and isolating these tumor antigen-specific TILs are technically kind of not non-trivial. And for example, in a few years ago, we had a study where we want to systematically analyze these MANA-specific T cells from non-small cell lung cancer patients treated with anti-PD-1 immunotherapy. So in that study, how did we study it? We actually combined multiple technologies, including single-cell RNA sequencing, single-cell T-cell receptor sequencing, and the assay called MANAFEST. So what we did is we basically used single-cell technologies to profile each individual cell in the TIL. And so that we can get the gene expression information as well as T-cell receptor information. And in parallel, we use the assay called MANAFEST, developed by our collaborator, Kelly Smith, to identify the manner-specific T-cell receptors. And how it works briefly, so you get exome sequencing of the patient, identify mutations, and then apply some computational method to predict putative neoantigens. And then you are going to use these predicted neoantigens to stimulate T cells extracted from patients. And if T cells recognize a specific tumor antigen, those T cells will expand. Right, so by sequencing the TCR sequences of the T cells and identifying the expanding clones, you're going to get TCRs that correspond to that specific neoantigen. So then we are going to use the TCR sequence, the particular CDR3 region sequence, as a barcode to screen our single cell data and to identify all the single cells along with their gene expression profiles from our single cell RNA-seq. So you can see this is a highly complex procedure. And after all this exercise, we identified like hundreds of cells that recognize manners. And by the way, here I'm mainly talking about the CD8 T cell and in that study. And also in my talk today, we are mainly going to focus on CD8 T cell. So it's a kind of a huge exercise. And similarly, in a parallel study, Kathy Wu's group from Harvard, they applied a similar strategy to study melanoma. And also they did a lot of experiment and identified thousands of manner-specific and melanoma-associated, antigen-associated T cells. And in both of these studies, you can see like we spent a lot of money, a lot of time. It's multi-year projects, right? So at the end of the day, we get thousands of cells. And this seems a lot, but actually when you compare to a typical single cell study, these are not that many cells. But this already represents the largest data set for which we have experimentally validated manner-specific T cells along with their transcriptome. Right? And then we ask, can we generalize it? Can we scale it up and apply it to many other patients, other tumor types? And answer obviously is not right now because, as I said, it's too expensive and time consuming. So that motivated us to ask, do we have a more efficient way to do this? Can we identify manner or tumor antigen specific T cells more efficiently and in a cost-effective fashion? So that motivated us to explore computational solutions, okay? And our exploratory data analysis suggests such a solution is possible. And for example, here on your left-hand side, I'm showing you a UMAP where we integrated the single cells from the non-small cell lung cancer data set and the melanoma data set. And here, each data point represents a cell, and different colors represent different cell types obtained from unsupervised cell clustering. And on the right-hand side, I'm showing you antigen-specific T cells represented using different colors. The red color represents manner-specific T cells, and the green represents melanoma-specific T cells. And so the blue and the purple represent bystander T cells recognizing flu and EBV respectively. You can see that these tumor-reactive T cells, including manner and MAA T cells, are separate from the bystander cells that recognize flu and the EBV antigens. Right? So if two cells are close to each other, it suggests their gene expression profile is similar. So because of this, you can see that regardless of cancer type, the tumor manner-specific cells, they kind of share some common gene expression program. That suggests maybe there are some features in the gene expression space that can be utilized to do cross-cancer type prediction of these manner-specific T cells. Okay, so after this, we started to build our computational solution. And here, given that we don't have huge amount of data, we prefer to build a more parsimonious model, although in principle, we could systematically scan all the genes associated with our phenotype of interest. But given that we only have 2 cancer types, right? So if we go too complex, perhaps it's not generalizable to other tumor types. Therefore, we just try to constrain ourselves to a very simple model. And after doing some literature review, we found that these three genes, CXCL13 and PD1 or CD39 and IL7R, are three genes frequently suggested in multiple papers to be linked to somehow to tumor reactivity. So therefore, we focus on these three genes. And from the exploratory data analysis, you can already see that high expression of CXCL13 and CD39 and the low expression of IL7R are somehow linked to the regions where the manner cells are enriched. So to rigorously build the model and test the model, we utilize this data set, including both melanoma and non-small cell lung cancer. And then we use the melanoma to train our model. And then later, we are going to use non-small cell lung cancer to test our model. Okay, so for the melanoma data, we only have 3 patients actually. So the way we build the model is for each patient, we have some experimentally validated manner cells. We also have some experimentally validated bystander cells, like those recognized flus and EBVs. And then for each patient, we are going to use this data to build 2 types of models. One is called the random forest model. One is called linear regression model, and both are like kind of supervised learning models. And then these models are built with 2 different data pre-processing methods. And one is with raw normalized gene expression data, and the other one is using the so-called saver imputed data to mitigate the sparsity and the noise in the single-cell RNAs. So with 3 patients, 2 machine learning algorithms, and 2 data processing pipelines, we have 12 models in total. And then we are going to use some model aggregation technique to aggregate these models to derive a combined voting and to make our final decision. Okay, so I'll ignore the details here. But so after we build this model, we actually derived a model based on imputation data, which we call manner score imputation or manner score I. And we also have a separate model based on non-imputed data, which we call manner score NI or manner score based on non-imputation. So how does this model perform? We compared our manner score with a few existing approaches. One approach is based on CXCL13 gene only, which was proposed by Dr. Zemin Zhang's group from Peking University. And another score is the so-called neo-TCR score, which was proposed by Rosenberg's group at NIH, where they used more than 200 genes as the predictor to construct a prediction model. And then we did different type of tests. And on the left-hand side, we did the cross-validation. So we used 80% of the melanoma cells to train model and 20% of like melanoma cells to test the model. On the right-hand side, we like use melanoma to train the model and then applied to the non-small cell lung cancer, which was not used in the training. And in both of these tests, you can see that the manner score approach actually performed the best and produced the highest ROC curve. And here, the highest curve actually corresponds to manner score. It's better than the other existing method. And here is gives you a kind of intuitive idea what the manner score produces. And here in this UMAP of non-small cell lung cancer data, the red means high manner score and the blue means low manner score. And you can see cells that we labeled with high manner score usually occur in this bottom left region, which correspond to a subcluster of effector CD8 T cells and then 2 subclusters of tissue resident memory T cells. And then after some statistical procedure, we can also determine a cutoff to call the manner score high cells. It turns out that CD8 T cells with high manner scores are mainly coming from these 3 clusters I mentioned, and 2, including 1 effector T cell subcluster and 2 tissue resident memory subclusters. And using this approach, we can also identify the putative tumor reactive clones. So here, 1 clone represents a bunch of T cells that share the same TCR sequence. CDR3 sequence. And because they share the same CDR sequence, we believe that they have the same like antigen specificity, right? So here in this plot, each column or each box plot corresponds to a clonotype or clone. And you can see within each clone, you have multiple cells. Some cells have high MANA scores represented using red, and some cells have low MANA scores represented using blue. Okay, so we define a putative tumor-reactive clone as a clone with at least 5 red cells or 5 cells with high MANA scores. And then if a clone is a putative tumor-reactive clone, all cells in that clone will be defined as putative tumor-reactive cells or PTRCs. So this allows us to identify the PTRCs and study them not only in the tumor context, but also in, say, normal lung and other contexts. Okay. And so if you compare the distribution of putative tumor-reactive clones in this UMAP, which is shown on the top, with the experimentally validated MANA T cells, which is shown on the bottom, you can see that our predictions actually reflected the behaviors of experimentally validated MANA-specific T cells very well. Okay. And then we actually also tried this approach to many other tumor types. For example, we applied this to a oral cancer data set, single cell data set. Here on the left-hand side, what I'm showing you is the experimentally validated tumor antigen-specific clones, which are in red. On the right-hand side are the MANA scores. You can see high MANA scores captured the experimentally validated clones very well. And here's another data set containing multiple types of metastatic cancers from the Rosenberg study. And again, left-hand side, experimentally validated clones, and right-hand side are the MANA scores. You can again see that they correspond to each other very well. And here is a Merkel cell carcinoma example. And this is a special type of carcinoma where the Merkel cell polyoma virus actually plays an important role to induce this cancer. And here the virus is got integrated in the genome to create a tumor. So the virus itself actually is a tumor antigen. And again, you can see in the middle are the experimentally validated MANA tumor antigen specific clones or cells. And the right-hand side shows the MANA score. They correspond to each other very well. And in this data, if you call all the MANA score, the putative tumor-reactive cells based on MANA score, you can see that over 99% of experimentally validated antigens, tumor antigen-specific cells actually are covered by our putative tumor-reactive T cells. And about half of our predictions actually can be experimentally validated. Okay, so together, this shows that although the MANA score was trained just using the melanoma data, actually it can predict, help us predict this tumor antigen-specific cells in many different cancer types and covering several different types of tumor antigens. So using this systematically identified tumor-reactive T cells, we can then characterize their transcriptional profiles. And here I'm going to run a little bit quickly. So basically what we found is the putative tumor-reactive T cells share many similar characteristics compared to the experimentally validated tumor-reactive T cells. For example, in general, the putative tumor-reactive T cells have larger clonal size in the tumor tissues compared to the non-tumor reactive T cells, as shown in this two box plot here. And we also characterize each cell using a bunch of gene set signatures. And what we found is from left to hand side to the right hand side, the tumor reactive T cells in general have higher tissue resident memory score, higher checkpoint score, and higher cytotoxicity score, and also higher TCR signaling score. And what makes us most exciting is now with this MANA score, we can systematically study the compare patients who respond to the therapy with patients who do not respond to the therapy, right? Previously, if you do experiment, and if you want to use experiment to identify the manner cells and then compare them, we can only identify these manner cells from a couple of patients, like one from responder group, one from non-responder group is too expensive, right? But with this computational tool, now we can systematically apply our prediction to all the patients we have. So in this clinical trial, we have about like 20 patients. After like excluding some poor quality data, we still ended up with more than 10 patients where we have single cell data that we can apply our manner score on. So after we apply our manner score to identify the putative tumor reactive T cells from all these patients, some of these patients are responders, some are non-responders. So we can then compare responders with non-responders. And then what we found is compared to non-responders, responders tend to have higher proportion of putative tumor reactive T cells in their tumor tissue. And also the mean manner score, the average manner score of all cells in the tumor infiltrating lymphocyte in those patients are higher for responders compared to non-responders. And then we also can study the gene expression differences. So we compare gene expression profiles from the responders to gene expression profiles of the non-responders within these putative tumor reactive T cells. What we found is for the responders, you see upregulation of genes like granzyme K and the CXCL13 and also PDCD1. And for the non-responders, the PTRCs are enriched. The upregulated genes include things like granzyme B, granzyme A, granulysin, interferon gamma, and these are like kind of typical effector T cell features. But you also see checkpoints like LAG3 and TIGIT, and this suggests these cells more like more resemble a exhausted states. But unlike the exhausted T cells characterized in the chronic virus infection scenario, where you should expect a high expression of granzyme K and the PDCD1, here actually for this type of cells, the granzyme K and PDCD1 are kind of downregulated in the non-responders, but they are upregulated in the responders, suggesting these exhaustion states are kind of a little bit different from the exhaustion states you would expect from the viral infection scenario. Okay. So this just demonstrates that using the manner scores, actually you can perform like systematic analysis of like gene expression profiles, compare responder non-responders. That was not possible if you just use experimental approach to identify these cells. Okay, and then I'm going to skip this, and then finally we also did a more deeper analysis of these putative tumor reactive cells and created subclusters of them and run some RNA velocity analysis trying to understand how cells move in this dynamic space. And it turns out that C1 here is a cluster that kind of has the high granzyme K expression, which is kind of corresponding to cells in the responders. And then C5 is a kind of stem-like cell subcluster. What we found is in all responders, we can see that cells, in the RNA velocity analysis, cells move from C1, this effector-like population, to C5, which is the stem-like memory population. Whereas in non-responders, you don't have this clear, consistent path, right? So this shows like cells in responders seem to have some consistent kind of process that's happening. So we are still trying to like doing additional studies, trying to further understand this phenomenon. Okay, so to summarize, we have developed a computational method called manner score, which based on 3 genes to predict the manner-specific T cells in the tumor microenvironment. And we have shown that it actually can also be applied to predict manner cells or other tumor antigen-specific cells in many other cancer types. And so this allowed us to study this type of cells in a more cost-effective fashion. And using this approach, we actually analyzed the non-small cell lung cancer patient treated with immunotherapy and derived some signatures that distinguish between responders and non-responders. And for our future work, ongoing work includes, we are going to expand our training data, obviously, as we collect more data. Hopefully we can train a better model, and hopefully we can use even more advanced methods. And we are also trying to understand using spatial omic technologies, trying to understand the interactions between our putative tumor reactive T cells and the microenvironment, like cells in the neighborhood, and trying to identify features that can help us better distinguish between responders and non-responders. And hopefully this will allow us to eventually build a pan-cancer atlas that help the whole community to better kind of predict a patient's response and help the patients. Okay, with that, I'm going to conclude my talk, and thank you all very much for your attention.
Thank you so much, Professor G. And I think the MANA scoring system is definitely very helpful. I do know like we have a lot of small biotech company leaders here. So hopefully afterwards, maybe we'll find some collaboration opportunities. So on behalf of CBA, we also want to present you this Brilliant Achievement Award for contribution to science. Let's have a picture together. Maybe over the CBA sign. We'll get ready for the next speaker as well.
All right, as a FD alumni, it's my great pleasure to invite our last keynote speaker of the session, another FD alumni, Kim Quintens-Lund. And Kim is currently the Vice President, Head of Regulatory Science and Execution at Alexion AstraZeneca. Kim actually has extensive over 25 years of regulatory strategy experience and regulatory operation expertise. Kim has served multiple regulatory leadership roles in both the US FDA and also several global pharmaceutical companies, including Eisai, Bayer, and most recently Alexion AstraZeneca. Today, Kim's share with us Charting Rare Paths, insights from a former regulator on the regulation of treatments for rare diseases. Let's all welcome Kim.
Thank you, and my sincere appreciation to the leadership of the CBA for having me here today. It's an honor and a privilege to be with you this morning, and my thanks to Julia for the invitation as well. And congratulations on your 30th anniversary. As I was introduced, oh, this isn't my slide. Oh, wow. Not sure what happened. I did not put the hieroglyphics on that slide. That was supposed to be the title of the talk. Yeah, so I want to talk to you today about rare diseases from my perspective, both in the industry and as a former regulator. As was said, I've spent 14 years at FDA and have had 14 years since being at FDA, kind of nice symmetry there. But most recently, I'm serving as the Vice President for Regulatory Science and Execution at Alexion, which is the rare disease unit of AstraZeneca. And I will say that working in the rare disease space has been such a privilege for me. I am a very strong believer in patient focus and patient centricity, and kind of by definition, you are much closer to the patients when you work in rare diseases. than when you are working in larger spaces. So when you're talking about clinical trials of thousands and tens of thousands of people in some of the larger diseases, we're talking about clinical trials with 20 patients. So I do need to say what I'm going to share with you today are really my own perspectives and opinions based on my experience. And so therefore do not necessarily reflect those of any of my employer or any affiliated organizations. So first I want to start, wow, all of the headlines now are in that interesting thing. But first, I want to start out with just some statistics about the challenges of having a rare disease. So first, there are over 7,000 rare diseases currently identified. And of those rare diseases, only 5% have identified treatments. And now I've lost the rest of my, all right. So in thinking about this, as a patient, if a patient is diagnosed with a rare disease, it takes them on average 4.8 years to be diagnosed. So again, stop and think about that. 4.8 years of seeing specialists. And on average, you see more than 7 specialists over that period of time before you can achieve a diagnosis of what your rare disease is. And again, only 5% of those treatments, of those diseases have actually treatments. There are, in the US, 25 to 30 million people that have a rare disease. Globally, it's estimated over 350 million worldwide. So while rare diseases are rare, defined in the US as less than 200,000 patients. Rare diseases, people with rare diseases are not that rare. They affect quite a lot of our community. Thank you. So, kind of building on what we've heard today between Senator Lamb and then all of the speakers before me, let's think about the drug research process. You're talking about a small disease population to start with. Therefore, you have small numbers of patients to enroll in your clinical trials. Oftentimes, the rare diseases themselves are very heterogeneous in how they present. So a brief example of this would be neurofibromatosis type 1. Patients present with plexiform tumors, which are benign tumors, but those can present themselves in patients in 8 different ways. They can affect their vision. They can affect their internal organs. They can present as skin affectations or lumps on the outside. So this makes it even more challenging to come up with ways not only to find these patients, to diagnose these patients, but then how do you measure whether or not a treatment is having an effect when there are 8 different manifestations of this one tumor type? And then when you think about this from a perspective of regulatory, the gold standard is a randomized controlled clinical trial, which is really difficult to do in 20 patients to provide adequate statistical power to show that evidence of safety and effectiveness. So let's talk a little bit about what the regulators are doing on this. FDA has a lot of initiatives currently ongoing. Some of them have been around for a while and some of them are relatively new. I'm going to focus on some of the newer initiatives. First, FDA announced last year that they have a rare disease innovation hub. Now, what does that mean? As a company, it doesn't mean anything for us per se. This is not a place for us, but this is a place for patients to come together. This is also a place for the individual centers within FDA to come together. And their goals are not only to enhance communication, but also to leverage the expertise in each of the centers at FDA. And then also to look for ways to accelerate clinical trial development for these. So they can advance regulatory science. They can look for ways to bring all of those together for the greater good. They also have the Advancing Rare Disease Cures, or the ARC program. This is something that is run out of the Center for Drugs. This is, again, a program which is kind of an umbrella program, if you will, that pulls together expertise within the Center for Drugs and pulls up expertise from all of the various review disciplines and brings them together, again, to think about ways that they can help to work with the review teams to promote and advance the development of treatments to treat rare diseases. There's also a rare disease, more specifically, a rare disease endpoint advancement pilot program. And what this is just what it says. This is an opportunity to have increased communications with both the Center for Drugs and the Center for Biologics on developing novel endpoints. Now, again, thinking back to those statistics, 7,000 rare diseases, 5% of them have treatments. We need endpoints for these diseases. So this is an opportunity to have those discussions with the agency to talk about what types of endpoints may be viable for showing the effectiveness of treatment or identifying the right patients to be in a clinical trial. These are important, critical type of discussions with regulators to ensure that what we do is effective in bringing these treatments forward. Small patient populations mean you don't have a lot of leeway. So you really have to be judicious in how you develop your programs moving forward. And then last but not least, support for clinical trials advancing rare disease therapeutics, or the START pilot program. Now this one, it takes a little bit bigger scope, and not only it talks about endpoints for discussion, but it's also talking about clinical trial design itself. So how do you leverage the non-clinical information you have? How do you provide confirmatory evidence? Again, the two adequate and well-controlled trials, that is the current standard for efficacy, is not something that is normally achievable. It's not feasible in a rare disease population. So how do you leverage non-clinical information? How do you provide that confirmatory evidence, going back to bringing in the endpoints, and how do you select the right population for your trial? So when you think about this, and I think too, you know, is a nice tie-in to a lot of the things that the panelists before me have spoken about, is we need to really advance not only the regulatory science, but the regulatory pathways and approval pathways to meet us where we are. The FDA standard of substantial evidence of safety and effectiveness has been in place since 1962. Happy to say that's even older than I am. So it's been around for a long time, but the science and the technology have certainly advanced. So there are a lot of things that we can think about that we can use to move these things forward. There are a lot of opportunities to further advance our knowledge and how we can capture data around natural history. Rare disease populations, it's not always an option to do a placebo-controlled trial. Small patient, I'm going to go back to it again, small patient populations, but also many of these diseases are life-threatening. So therefore, placebo control is probably not ethical to do in that patient population. So how do you show a change, an effect from the treatment itself? And one way to do that is to use natural history studies to show the natural progression of that disease. We can also think about innovative clinical trial designs. Now, I am not a statistician by any stretch of the imagination, although I did play one in a DIA training video a long time ago. But nevertheless, there are methods that you can use where you can do interim analyses, and you can do Bayesian studies. Did I say that right? Bayesian? Okay. Bayesian clinical trial designs and other types of clinical trial designs that allow you to build on the knowledge that you're capturing to further make clinical development more efficient as you go along. And then last but not least, we've talked a little bit about it already today, real world evidence. Been a lot of discussion about that over the years and how you can leverage real world evidence to help provide that additional piece of information to help show the safety and effectiveness of the product. Now you can hear me still as a former, once an FDA, always an FDA, substantial evidence of safety and effectiveness, substantial evidence, safety and effectiveness, right? I'll say it over and over and over again. I don't think you need to change the standard for approval for a rare disease. In fact, I don't think we should change the standard. I think where we can move things along is based on that regulatory science. I think where we move that along is how do you provide substantial evidence of safety and effectiveness? And that is based on the regulatory science and innovation, you know, the development of novel endpoints, the development of all of these things. I think that is where the future of this lies, not in changing the standards, but in changing how we reach them and leveraging all of the tools that we have being developed now, that we've already developed and moving forward. There is also a lot of talk right now of a new path or a new ability to have a conditional approval, which would mean that approval based on less than the normal standard of evidence, but provides most of this in the post-approval setting. But to build on that, I would say I would want to exercise caution. I'm an advocate. I'm very passionate about treatments for rare diseases and those patients. I feel very passionately about that. And to that end, you would think faster is better. We can get the patients the treatments better sooner. Isn't that a good thing? Yes, but there are implications when you look at things like conditional approval that impact access. And here in the US, some payers may not cover a treatment that has less than the full standard of safety and effectiveness that FDA requires. And there's a concern that then if the payers don't provide reimbursement for these treatments, patients won't have access. And this is contrary to the very heart of what we are trying to do when we develop these treatments. There's also a thought that patients deserve treatments that don't give them false hope, but yet meet the same standard of safety and effectiveness that other diseases are required to meet. And then last, but certainly not least, when you think about trials for along the lines of gene therapy trials, you have implications on future treatments. So to treat somebody with a product that may have less than the standard of effectiveness and then eliminate them from consideration for further treatments is something not to be taken lightly. I would argue that FDA has been very flexible to date, and based on all of the initiatives that they have going on, I think they continue to understand how important it is to develop treatments for rare diseases. And in fact, even with the uncertainty of the current administration, even looking at, I have a background in regulatory policy, so I have to admit, I looked at the budget proposal for FDA, but there are multiple mentions of supporting the development of rare diseases, even now. So with that in mind, I actually think the future is quite bright for rare diseases. I think the science is advancing. I think the regulatory, and this is not limited to FDA, I think all of the health authorities globally have recognized the need for doing this. And I think that means that we have this great opportunity. We have this great opportunity to bring regulatory science along into these regulatory pathways. And I think the possibilities are endless. So with that, I would like to remind you, this is Tristan. This is an actual patient that was treated with a product that Alexion has developed. He has lysosomal acid lipase deficiency syndrome. We have an enzyme replacement therapy for him. And again, rare diseases bring us closer to our patients. We have pictures like patients like Tristan all over our offices for Alexion. And it's one of those things that keeps me driving to keep thinking about new pathways, new ways to bring these treatments forward. So I would encourage all of you, regardless of what disease you're treating, think about the Tristans that you're providing benefit for as you move forward. Thank you for your attention.
Thanks, Erland, for a wonderful talk, Kim. We do appreciate the attention to the rare disease patients. There's not only just one Tristan. I think there are many other patients waiting for the treatment. We also want to present you the Brilliant Achievement Award for your contribution to science. Yeah, what is give this time. We're a little bit over time behind our schedule. So we do want to be very quick. I understand we have I will have the attendees here in the room lined up for the questions already. So before that, I also want to share, we have quite some questions online. I do want to share very quickly with the attendees here. So online person already shared their appreciation. For example, people are asking about the DIA code. So Maria, congratulations. You already got some additional attendees. Second question is for Dr. Lee, but we'll be very quick. People appreciate your talk, great talk. They also wonder how AZ is actually initiating the process of a new clinical trial as a project. So another question for Dr. G, how to find the 3 gene signature and calculate the amino score will be also quick. So I'll come back to in-person attendee here, Professor, Dr. Yeah, go ahead, please.
So I have 10 questions. You pretty much could forget about the questions Angela asked. Quick question to Dr. Bob Lee. Good question to Dr. Bob Lee. Good question. Could you hear me? Oh, great. I really admire your global vision on Mars. Now, just given the ongoing trade tensions between China and US, so what do you foresee the challenges in terms of both sharing data and also delivering your global vision?
Thank you for your question. And indeed, this is geopolitical uncertain times, trade tensions and all. But as pharmaceutical company and healthcare professionals, our mission is about the patients. So I think let's not forget about that. And that's really the center of everything we do. So in a way that should transcend geopolitics and things that we really can't control and even predict. So in AstraZeneca, we have global clinical trials that includes China and the US. It's been done before and during and after trade tensions. We have diversified supply chains in the US and in China and around the world. So largely, I'd say it's not really affected despite all the tension that's going on around the world. So I think our engagement with government is completely transparent and it's collaborative. The government really has an important role to play to expand access to and accelerate innovation so we can cure cancer and other major diseases for patients. Thanks.
Thank you, Dr. Lee. We do have a question for Professor G, but Professor G, can you please just, I know that question is a very big one. I understand our attendee want to get more detail, but can you please probably use 1 or 2 sentences just to describe, give him a very quick answer.
Can you repeat the question again?
How do you find the 3 gene signature and calculate the MANA score?
How do we find the 3 genes?
How to?
Oh, how do we calculate? Okay, so so we train a model. Basically, it's kind of, you can think it as a mathematical model, right? So you have some y, which is says whether this cell is likely a MANA specific cell, and you have some x, meaning that for this cell we can have the measurement of that 3 genes. So based on what you observed for x, the gene expression level, we want to label that cell as a MANA or not. So this is a mathematical model, and how you estimate that mathematical model, we use the machine learning approach called a random forest and linear regression. Maybe some of you heard of linear regression, right? So you just feed the model, and the computer will tell you how much weight you give to each gene and combine them. And random forest is a little bit more complex. It's a nonlinear model, but essentially you can also view it as a model with many parameters, and the computer, after seeing the training data, it will decide how much weight or decision is going to make in order to get the final value. So that's some kind of a non-technical explanation of how we calculate this. So once you train this model, if you have new data, you are going to measure that 3 genes again, right? So once you have that 3 genes measurement, you are going to feed that measurement into our trained model, and our trained model will produce our output and tell you, oh, this is likely a MANA cell.
Thank you.
Thank you. So, we're trying to be on track. So maybe I will ask the final question before we conclude the session. And I know audience have a lot of questions to our keynote speakers. You can find them during our lunch break and the coffee break for more discussion. So my question was probably to Kim and Maria, and also maybe Bob, you can also comment. It's a general drug development question. So I heard the common theme of your talk today is the patient focus, right? So patient focus, real world evidence, using novel approach to expedite the drug development. It's applied to chronic disease, in obesity, rare disease, and oncology. So if you just give us one or two sentences in your specific areas, what do you think is a more really practical in the next 2 years that individual progress that we can make to achieve that goal, to really leverage more patient-focused evidence to expedite the drug development? Thank you.
Okay, so I'll start. In my view, one of the key things is the collaboration with the patients themselves. We've moved away from the traditional clinical trial design. We talked about some innovative clinical trial designs too, which were, we talked about decentralized, we talked about the advent of technology. I think, no matter what type of disease state you're talking about, you have to partner. You have to partner with the patients. There have been so many studies that show the benefit. I think I'm hoping that we've gotten out of that moment in time where we all had to explain why working with patients was important, to understanding that there is an actual value from a business perspective of doing this. But you have to partner with your patients in order to appropriately address the problems that they're facing, develop your clinical trials in ways that they can participate, and to have medicines that are available to help them achieve a quality of life.
Thank you. I guess as was mentioned in my introduction, previously to DIA, I was at a patient advocacy organization as head of science. And one thing that I remember from those days is that patients are people, and people have a lot in common, and we all want to be healthy, we want to have a good quality of life. I think it's so important to remember that, and to, as Kim said, incorporate the view of the patient, not as a checkbox, but from the beginning of the whole process, even before the clinical trial design discussions, all the way through the access discussions. And the way to be able to do that is really to also have a way to educate
in general about the value of clinical trials and to make this education very accessible and equitable around the world. There's a lot to be done. And I feel like nonprofit organizations have a role to play in this space, but we also, as some of us, have a role to play in order to be able to make that education accessible. And furthermore, to change the way we educate our future generation of physicians and clinical workforce in general, because I think that's where the primary interaction with the participants and patients starts. It starts either in the physical therapy office or in the primary physician's office. Maybe for some it starts at the clinician and oncology office, but it's so important to provide that education and to make it accessible so everybody can make informed decisions. And then the final thing I was going to mention is I actually did have a question which I'm going to follow up with the break. I'm curious if in the rare disease space where families are such active advocates, if artificial intelligence is a tool that's being taken up more by rare disease patients than others, because I think that's one thing that we all know is patients now are getting information through artificial intelligence algorithms, and I'm sure that has a role to play as we do some of our outreach.
I totally agree that this is a global movement where we all have a role to play, no matter which sector you come from and which angle and perspective, because it's really on behalf of those patients in need. And to answer the earlier question online, AstraZeneca is rolling out a series of initiatives built on a so-called Chorus network, which stands for Community Hematology Oncology Research Unleashing Science. And this is really a next generation of clinical trial design through decentralized trial methods, real-world evidence, big data, AI automation, getting real data back in real time to provide the evidence base for shaping practice guidelines, expanding access, increasing the application, and also ultimately even have regulatory impact down the road, as this is really a fast-changing field. So we're getting ideas, bouncing ideas with investigators, scientists, physicians, and other healthcare professional societies to together co-create that future where clinical trials can be accessed by the 90+% of patients, the vast majority of patients who miss out. The onus is up to us to enable and provide that access to those patients wherever they live, whether they may be anywhere around the world. So I totally agree with your comment, Maria, that everyone has a role to play. Thank you.
I really want to echo what Bob just mentioned. As a clinician, as a global clinical lead at AstraZeneca, I'm leading, multiple studies of phase 1, phase 2, even phase 3 trials. I do think the innovative thinking from the beginning for the clinical trial design is also very critical. Also, with the past result recently, where we just presented at ASCO, I also believe that machine learning, like a big data analysis, like Professor G just introduced, I think that one is also very critical. We do want to apply those new methods to our design to the end of the trial. We do want to bring our new medication to the patients as soon as we can. Yeah, with that, I think.
Yeah, so we will really thank all our keynote speakers for their wonderful presentations and insights. I will we'll conclude this session. We have a 15 minutes coffee break before we move on to the next session. So let's give another round of applause to our speakers. Thank you.
Thank you, everyone. Also, you can utilize the time to, share your questions, share your thinking with all our speakers here. Thank you again, everyone.